Sukanta Chatterjee. So I request moderator Dr. Piyali Bhattacharya to later introduce all your panelists. Now I will call our Professor Kalpana Datta, the president of the WBAP, to address this gathering.
Okay, thank you, Dr. Shapon. A very good evening to all of you. I welcome you, all of you, in this digital platform. We are very happy to see you all the August panelists in this platform. And we are having a series of webinars on the different topics, with different burning topics, in a small chunk of the disease, not in at a whole. So the last session we had in child abuse, and next this is on the adolescent health. And for that, we have a coordinator, very own Professor Sukanta Chatterjee. He will coordinate the thing. And the moderator is Dr. Piyali Bhattacharya, ma'am. And I welcome all of you, the panelists, the other faculties also, I welcome, and the attendees. There are many attendees have joined. I'm really happy to see all those things. And I'll now hand over this stage to Dr. Sukanta Chatterjee, sir. So please invite the moderator, and you just coordinate the whole program. Thank you, sir.
Well, good evening, Mr. Chairpersons, Chandra Mohan and Amit Mohan ji. And good evening to all the faculties and the viewers and the moderator. Today, in this webinar on adolescent health, unlike other days on adolescent meetings, this is the viewers are not all AHA members or adolescent health practitioners. There are many pediatricians in this audience. Therefore, I'll request the moderator and also the panelists to discuss within their topic the basics as well as a little advanced aspect of that subject, so that the audience could get both the flavors. With that, I would request the
Sukanta, if the chairpersons can give a small introduction to the whole topic.
Moderator.
Yeah, please. Chandro is very well known for discussion on adolescent. We want the adolescent chapter to be there, active in Bihar also.
Yes, open one chapter.
Yes, I'll request Chandra Mohan first, then Amit Mohan to speak before the scientific program really starts.
Okay, Dr. Chandaman, please.
Yes, Chandaman.
So thank you, sir, for giving me this opportunity. And I will not take much time. We all know that Piyali ma'am has been stellar. She had a stellar role in AHA whenever since 2013, when I have started taking deep interest in AHA. I have met her on all the occasions, and she is a marvelous person to organize the thoughts and topics. So I believe she has an extremely well-read panel, and the panel will be very useful for all of us to know the things and what are the common concerns of the all IAPs. Her panel will be taking care of. So Piyali ma'am, you are welcome. Prior to that, I would ask Dr. Amit to please say a few words.
Good evening, everyone, and thank you very much for giving me this opportunity. I don't have to add anything. I just want to say that this is a very upcoming topic, and as you already said that Piyali ma'am is one of the pioneer in adolescent medicine. She has a lot of interest in that, and the panelists are also very good. So it will be a very useful webinar today. Thank you very much, and over to you, Piyali ma'am.
All the topics have been chosen so well by Sukanta sir that the body image, screen time, depression and suicidal tendencies, and risk-taking behaviors. So these are the cornerstones of the day-to-day practice of adolescent health. So I believe the audience will be immensely benefited with all these discussions. Thank you. So Piyali ma'am, please.
Yes, now Piyali madam, please start the program.
I will be sharing my screen, sir.
I should introduce Piyali madam first. That in the introduction, besides the Vice President of IAP and a very active members on adolescent health, her contribution is great. On any topic on adolescent health, she can speak. So that is introduction that I can give for her. And I'll request Piali to continue this panel discussions. And for the audience and for all of us, we are interested.
Sir, am I audible and visible?
Yes, yes, both.
Thank you so much, sir, for your kind introduction. Thank you, Chandra Mohan, and thank you, Amit. So today I will start with a big thank you to the organizers of e-library. I do not know whose brainwave this was, but it is an extremely useful brainwave, and thank you so much all for this.
It is Dr. Atanu's brain.
Oh, acha, acha, acha. So wonderful. So thank you so much for this, because more and more we know about the adolescent, more and more we learn how to deal with our own adolescents. So the first topic of today, just excuse me a moment. I'm on the panel. So the first topic for today is my most elite panelist, Dr. Sumita, who will be speaking on body image issues. So Sumita, the first question is, what do you understand by body image issues? Sumita, you are mute. Please unmute yourself. Sumita, unmute yourself, please.
Thank you. Am I audible? Yes.
Yeah.
Thank you so much. Thank you so much to the entire team from West Bengal IPAHA for having me on this panel. It is indeed my privilege, and it's wonderful to be on a panel with Dr. Piali Di. So thank you, ma'am, for this having me here. And before we go to discuss about body image issues, let's try to understand, first of all, what we mean by a body when we talk about the body image per se. So this is nothing but a person's perception, his or her own perception about their physical self and what they think about it. The feelings could be positive, it could be negative, it could be both. So this is what we mean by the body image per se. And once there is a disturbance in this perception, so once we understand the definition of a body image, any disturbance in this perception leads to the body image disorders. So we call it as a body dysmorphic disorders. So let's go ahead and discuss more about it. Dr. Piali, can I talk about the definition?
So, a moment we take to talk about the body image and when it becomes an issue, you know. We all think we are thin or we are fat, we don't have dark hair, our complexion is not so good. So most of us are a little maybe dissatisfied with our own body images, you know. But when this dissatisfaction becomes a persistent worry, or we are unable to focus on our daily routine, like our studies or our career or our food, it really becomes an issue at that point of time. So body image, invariably, we think that girls are more concerned. No, both boys and girls are concerned about their body image issues. So Sumita, my next question is, what is BDD or body dysmorphic disorder?
So this has been described and defined very well. So there are very, very definite pointers to this. And I think each one of us has to be really aware. So it is defined as a common and often severe and a complex disorder. So it's not something very simple and direct, but there are various aspects to it, and it is characterized. The important thing is an excessive concern about one or more perceived defects. Here, the important word is perceived, because it may be a very minor-ish point from others' perspective, but the person himself or herself thinks that it's something really, really huge, and they are all the time concerned about it, as you rightly mentioned, Dr. Piali ma'am, that it actually affects their daily routine. So they are constantly thinking about it, and there is a repetitive behavior involved. So this is what we call as a body dysmorphic disorder.
So Sumita, we have a Bible called the DSM-5, you know, at the present moment, that describes a lot of disorders. So in the DSM-5, what is the criteria for body dysmorphic disorders?
So there are very, very definitive criteria here. The first is, of course, the appearance preoccupation, that is the physical appearance. So the person thinks that they have something which is a slight defect or a flaw, but it may not even be existent, but they are really, really concerned with their physical appearance. So that's the first important point to be noted. They have the repetitive behavior. So this is something which has been introduced currently in the DSM-5. The repetitive behavior, the compulsive behavior in response to the appearance. They may stop to look at the mirror several times. They might repeatedly be combing their hair. They might touch their nose, look at their nose, think that their nose is disproportionate, etc. So anything that is repetitive. Then there is the clinical significance. That is, this preoccupation must be so significant as to distress the person. So it impairs their functioning, whether it's a social, it's occupational, the academic functions. All areas of their functioning are definitely affected because they are constantly thinking and preoccupied with this particular imagined or perceived defect in themselves. They also have, yes.
So if you think that the child is very worried about the physical appearance, say he's very fat, do you think it is also eating disorder?
You have to differentiate it from the eating disorder. So that is, this is something which we actually must look at very carefully, because the eating disorder is something different and you have to differentiate it from this. So it has to be, the appearance is a preoccupation rather than eating. So they are, they are more concerned about their appearance. And they talk about themselves being, as you mentioned, too thin, too fat, etc. But the concern here is that they are not only looking at eating. So there's a differentiation there which must definitely be looked into. And then we also have some specifiers. So this is a muscle dysmorphia, wherein this is especially amongst the boys, but it is also there amongst girls, wherein they think, especially the boys, they keep looking in the mirror and looking at their biceps, thinking that their biceps are too thin, they need to be bulked up, they need to have a six-pack abs, etc. So that is the muscle dysmorphia. And then there's also an insight specifier, wherein it indicates a degree of insight, that is, whether they think that, they are too ugly or they look too deformed. So these are again pointers towards this disorder.
So if you say that, then, if you say that, then how frequently or how do we encounter them very, very often in our population?
Yes, actually it is prevalent. It's just that probably we are not aware to pick it up, because most often these adolescents do not come to us with these complaints, or rather they are not brought in either by their parents or by anybody in their family saying that they have these issues, because there's a sense of feeling shy to talk about it. There's a sense of, thinking that they may be ridiculed, etc. So if we look at the prevalence, yes, especially among the adolescents as young as 10 years of age before diagnosis, almost 2 to 5% are having this issue. As we go into college and adolescent students, it is 3%, adults again 2 to 3%. So there are age-related differences, but yes, it is definitely prevalent. And the mean age is the adolescent age, 16 to 17 years. And by the time they're 18, definitely a lot of cases are there. And as you rightly mentioned, it's not only females, there are these issues in males as well.
So, Sumita, I know of a case of a boy who was just simply worried about his acne and kept looking at the mirror and was brought in by the parent because he had already consulted 6 dermatologists, was going in for a cosmetology appointment and things of that kind. So can you recount a case where you have had such things?
Yes, I have. Can we discuss this case? Because
yes, please.
Yeah, this is not the. This is another girl, a 13-year-old girl. The mother brought her in actually, saying that the girl was, there's a younger sibling at home, and this adolescent was always very rude to the parents. She didn't want to talk to the parents anything about school. So there was, the moment they spoke anything or asked her about what activities were happening in school and why she was, not being part of it, she used to start crying. And the reason the mother brought her into me was that she was not willing to go out to any social functions, especially any family related functions. Definitely it was a no-no. So this was the main reason why she was brought into the clinic. And
So did you do
yes.
any assessment for the child?
Yes. So of course I had to talk to the girl, and the head's assessment was done. And as I was talking to her one-on-one, she started slowly opening up, and then she started telling me, when I talked about her weight, etc. She said yes, she felt that she was too fat, and very, very slowly, and upon repeated prodding, because I had to ask her, has anybody told you that you're too fat? And that's when she actually blurted out and said, yes, my classmates talk about it. They're always teasing me. They're saying I'm fat, I'm dark, my complexion is very, very, she was a little bit of, the brownish, the wheatish complexion. I wouldn't really call her dark, but then that's what her classmates used to say and tease her. And that was the reason that she felt really, really insecure. And that led to all the, her behavior at home, because she felt that her parents were not understanding her situation, and she felt too shy, and she was too insecure to go out and meet people. So it was a kind of an insecurity in meeting and going out to groups.
So what are the various aspects that you feel are there of body image?
So there are, it is said that there are 4 aspects of body image. One is the way you see yourself. So that's the perception, the way you perceive yourself. And then the next is the way you feel about it. So you perceive yourself in a particular way, and then you feel whether you feel good or you don't feel good about it. So most often these people don't feel good about it. So that's the affective aspect. And then the way you think about it. So are you thinking and believing that you're not good, you're fat, you're not, you don't look great, etc. So that is the cognitive. And finally, what do you do with it? So that's the behavioral aspect. So are you really, as you mentioned, looking at going to see another doctor? Are you going in for cosmetic surgery? So these are the behavioral aspects. And usually all these 4 aspects are there, totally existing in a child or in an adolescent with BDD.
So action follows thought, as you said. So all these things get together and maybe seen in one child itself, that it is an intermix of perceptual, affective, cognitive, and behavioral issues in these children. So this is another case where a 12-year-old comes for a catch-up vaccination. He's well-dressed, but he is wearing a cap and he refuses to remove it. Now, once you take up this child, he is wearing the cap everywhere. He reveals that there's some acne on his forehead, and he's used his creams and medications. It's not reducing. So he prefers wearing the cap to hide the burst of the acne. So are there some cues that would lead you to a diagnosis in this case?
Yes. So you have to watch out for, in other conditions, we call them as red flags, but here we call them cues, because you have to look out for certain signs which are there. They are always subtle signs. So it's the first thing to note is that there's an excessive concern, or sometimes the adolescent or the child is distressed over something which otherwise we would think is a minor flaw. Or in fact, many a times it is also a non-existent flaw. So something which is either very minuscule or which is really not existing is actually troubling the particular child or the adolescent. So that's definitely one pointer that there could be a body image issue. The next thing is that there is the child is not able to concentrate either at school. The child is asocial, does not want to get into any group activities, does not go into a place where there are crowds or more people around. Sometimes since they perceive that there is some issues with their skin or there's acne, there could be skin picking. So repeatedly they are looking and touching their skin. They're trying to get rid of something which they feel is disfiguring them, etc. So that's another pointer. They try camouflaging, as in this child here, this 12-year-old boy who was all the time wearing a cap. So sometimes they also, the girls especially, go in for a lot of makeup. So they spend a lot of time getting dressed because they are trying to cover up what they think is a perceived flaw in their skin. So that's another pointer. So if you find a child or a girl, adolescent with a lot of makeup, please be sure that she's trying to hide something. And the other behaviors, sometimes they repeatedly ask. So they want reassurance. They keep asking, how do I look? Is my dress good? Will I look cool if I, comb my hair in a particular fashion, etc. So they are actually trying to seek some reassurance. Then there are others who keep thinking that, so and so is watching me. They are judging me. They are looking at the way how to see how I look, etc. So that is called as referential thinking. And another pointer is that, as you just mentioned, the child has seen so many dermatologists, so they are not satisfied, and this is common, very common with dermatological issues. So they keep jumping from one practitioner to the other, trying to get solace and a solution for their issues. Sometimes they might even go to the extent of going in for surgical treatment, especially a plastic surgery, etc. So that is something which is a pointer. And they also tend to believe that if they undergo these cosmetic procedures, they will be transformed and it's going to fix all their problems. So once we find any of these cues, any of these pointers, it's definitely up to us to, have pointed questions in the interview to try and pick out these children with BDD.
Concerns about the child's own body image. Fine. So tell me, the questionnaires that you use, are they easy? Are they simple? Are they open-ended questions? What kind of a questionnaire is used?
So actually the BDD questionnaire is very, very simple and easy to administer. There are only just 4 questions on that. It can be administered by anyone. It does not really need much of training. So the first question is, what is your concern? And do you think any part of your body is especially unattractive? Now, the moment you get a yes to this, that's when you start asking the other questions and administering the rest of the test. So if you get a no to it, then straight away stop it, because you understand that this particular child or adolescent is not going to fit into a body dysmorphic disorder
Issue.
at all. Yes, yes. So once they say yes to the first question, then you ask more and more pointed questions until you're able to fix up as to exactly what is troubling this child or this adolescent. So you have to ask whether it's the face, the hair, the nose. So commonly it is issues related to the skin, the hair, the nose, the face, the other body parts. In the boys, it's usually a preoccupation with their muscles, their genitals, etc. The girls are concerned about their breasts. So these are the issues which they say that they could point out and say, yes, this is what is troubling me. And then you move ahead and ask them, is this actually preoccupying you? Is it really something that you're all the time constantly thinking and worrying about? And then finally you ask them, what is the effect on your life? So is there a lifestyle change? And is it interfering with your day-to-day activities? So it's a very, very simple questionnaire, very, very sensitive, almost 100%, 94 to 100% sensitivity, as well as extremely specific. It's almost over a 90% specific test. So very simple to administer, and it will definitely give a pointer to the existence of BDD.
So these are some common issues. The complexion, I'm dark or I'm fair, or my nose is a little crooked, or there's a scar. And acne is, of course, these adolescents are very worried about their looks and their acne. And of course, the unequal size of breasts, boys with gynecomastia, and girls also with their abdominal shape, size, whether it's a pear-shaped. Sumita, one thing that I would like to ask you, that with this upcoming pandemic of obesity, what is your take on obesity and body image issues?
Yes. So most often when we are young, the younger obese children are really not concerned. But once they come to a certain age, say around the middle school, that is the 9-10-year-olds, that's when they start, because they start getting teased at school, they start getting pointed at, they may be excluded from their activities, etc. So that's when the obesity could be an issue with the child's body image. So they could deal up because we understand the
So
cycle.
it could go both ways, it could go in a good sense, it could go in a bad sense also. They could go into depression, they could self-harm, that too. And a Jwalant example is our javelin thrower who set a world record. He was obese, and in order to make him a little thinner, his uncle took him for these sports activities. And look at Mr. Chopra today. He is now the topmost in javelin throwing in the whole world. So a little bit of guidance maybe with these body image issues would of course help these children. So for the parents, the message goes that it is not the child's body, his shape or his size which actually matters. Be proud of her or him for the things that aren't related to appearance, say his interest, his activities. So focus on what the body can do rather than how the body looks. So these are few things that would actually be very, very useful for the child. And the part of healthy eating and physical exercises can't be stressed less. And appreciating on your own body, being proud of how you are, accepting and valuing people no matter how they look, and avoiding any subtle comments like other children calling oh motu, oh patlu, oh natu, things of that kind. And let everyone in the family know that teasing about weight or about appearance is not okay. NOT, not in capital letters, okay. And one more thing which the child should understand is that you must watch the media critically and carefully, because media literacy is something which our children, our adolescents still don't have. And media is one thing which influences the child very much, the adolescent. If you remember, there were ads on complexion. There was a particular cream saying that it will make you fair. So remember that these things affect our people. So when we talk to our children, our adolescents, we should teach them media literacy. Thank you, Sumita. That was very kind of you to come up with these cases. And I hope it is been fruitful. Thank you so much.
Thank
So
you.
I
Thank
will
you.
invite Dr. Chentil now. Dr. Chentil, are you here with us?
Yes, madam.
So today's topic that we need to discuss is risk-taking behavior. So risk-taking behavior. Can you first explain what risk-taking behavior is?
Yeah, very good evening to especially our respected Sukanta Chatterjee, the coordinator and the chairperson of AHA, and the coordinators and respected chairpersons, Dr. Chandramohan and Dr. Amit Mohan, and all my co-panelists. A very good evening to all. Let me go to the topic. Say this risk-taking behavior, it can be defined as the behavior or actions that lead to mortality, morbidity, and social problems among adolescents. What type of actions? The actions that affect one's physical, psychological, and emotional health, actually. So this risk behavior usually results from a lack of knowledge and understanding. And it is a sensation seeking which happens when a decision to act is taken impulsively, without thinking, based only on feelings and desires. These acts have no planning, but are encouraged as fun and daring. Often, these are mistaken by the adolescents as adventure.
So these are a few of the risk-taking behaviors that we usually come across. See, when the life becomes tough, when they move out of their parental guidance, they go for the peers and they move out of their comfortable homes. So life becomes a little difficult for them. 90% of the adolescents will adjust to these hardships also, but many of them will also deviate and go for substance abuse, for alcohol, for drunken driving. And so these risk-taking behaviors keep cropping up. So can you recall a case, Dr. Senthil, which you had, which had some risk-taking behavior and which you could attend to?
Yeah, this 15-year-old Setu of recently was not attentive in his class. He's in 10th standard, but you know the volume of emotions. But he looks sad and does not talk with anyone. He has a lot of schoolwork to complete, but he cannot focus on his studies nowadays. And his mother tells the history that of late he has started smoking his father's cigarettes. So with this scenario, we went on for the health assessment, and from the history, we could not note certain points. Can we go to the next slide, please? The assessment revealed that he was close to a girl with a friendship in his class, and due to a small misunderstanding, she avoided talking to him. So he was very upset and stopped mingling with parents, and with friends and parents. He didn't mingle properly. He was too stressed, and when one friend advised him to take cigarettes to relieve his problem, he was afraid to ask money from his parents, so he started smoking his father's cigarettes. So what are all the points we could gather here is he had a infatuation or probably a small affair, initial affair, and probably he thought this is going to have a relationship, and he thought he has ditched him. And so some of the peers, instead of advising him what to do next, he had advised, and he succumbed to it. And of course, you see that the parental role modeling also was there. Parent is usually taking the cigarettes, so he also was vulnerable, and he couldn't confide what he wanted because they were strict, and the parenting style was also different. And we know that he's also too stressed because he has got the his girl bestie is not talking to him, and so he has thought that to relieve his stress, he is going for a risk-taking behavior. So he has to see that he has to cope up with this stress by.
So, Dr. Senthil, how would you actually, do you know of a good method with which you could counsel, which our pediatricians could use usefully?
Yeah, he must actually, this is the approach for counseling actually. This is the gather approach. Once he comes to us, you can ask him, you tell him that whatever you say, we'll have it. It is a private affair. You can, and here we say always that during counseling, we have a separate sessions for the adolescent and the parents, and together also. So they ensure the confidentiality and the privacy is crucial. So greet and introduce him. Get get his confidence. So ask and listen actively. What is his problem? You must have a very listening attitude, and your whatever counseling session, you must be always focused to whatever he says. Tell the relevant information, whatever is possible in his limits, and help exploring options, and give him a plan. Let him decide what he is to decide and help him to decide. So explain and review and ask him to come up again for follow-up, and if necessary, we'll go for it. So this is the counseling approach we used to take in a session.
Actually, this is something that one needs to practice, because what we tend to do is we make errors of judgment. We make errors in counseling. So what we do is when they say that, yes, I've had a cigarette, we immediately judge and we say, oh, you're having cigarettes at this tender age. Oh my God. And then we start giving them sermons. Oh, nahi peena chahiye. You should not be doing this. You should have come from good families. And then we preach them, we moralize them, and then tell them we never used to do this. And we interrogate too much, we put them in a criminal box and we say that you've done so much wrong, and we point fingers at them. And then we give unwarranted reassurances. Okay. You come and confide in me, and I will do everything for you. Things of that kind. So we do make errors in counseling. And as Dr. Senthil said, gather approach is a wonderful approach by which you can help these children. Of course, maintaining the privacy and confidentiality of the child. there are some therapeutic interventions, Dr. Senthil, can you describe?
Yes, definitely. These adolescents need life skills development. They have to be incorporated of this problem solving, decision making, and negotiating, because these are the critical. The life skills, core life skills, which has to be taught at a younger age, and so that they can inculcate in early adolescence itself. And
So
how
a
to
little on
manage-
the life skills as well.
and you have to manage the stress, anger, and all these things. They know they must cope up with the stress. How to cope up with the stress? How to confide with a extra parental or a teacher or a parent. Sit with them, talk with them, and of course, life skills. You can this will help them for a positive thinking and a positive behavior. Of course, they will know self-control is the option here. And these are the skills, life skills framework. There are these thinking skills, social skills, and the negotiation skills.
So
This is the whole gamut.
basically we are targeting the life skills. So prevention is better than cure. So can you explain how to say no?
So this is the very important for adolescents. They must be actually taught in the early adolescence to say no. This assertiveness, this should be come from the home itself. Suppose they are reading for the next day's exam, and mother tells her, "You come, go and do this work for me now." Just tell the mother that now it is not the time I'm reading. I'll definitely come and I will do whatever you tell me after half an hour or 1 hour. So this is you inculcate from the home itself. So that in the next time when you go outside, the same thing, you will know how to say no. So initially you say very politely and softly with a smile, especially during the peer pressure. When smoking cigarettes or any other substance use or anything like that, when you say no, you must still, there will be pressures from the peers. Yeah, it's the first time, just try. So you must tell it firmly. If not, again, they are stressing, give a reason, suggest an alternate activity. Otherwise, even still they are pressing, talk about your own feelings. I don't like to do this. So, and just walk away and ignore. And if necessary, you tell an adult that this is the situation and try to avoid the situation. So assertiveness is a very basic life skill, and this has to be never argue, don't get angry, don't use harsh language, just say no.
So can't you tell your mother, can't you see I'm studying? So why do you have to talk to me like that now? Go away now. So instead of that, you can clearly explain, as Dr. Senthil has said, that I will be back with you later. So don't get angry, don't use harsh language. Now about prevention, Dr. Senthil.
Yeah, prevention, pediatrician's role is also definitely, because we are all gatekeepers. We have to have a careful attention for this comprehensive risk assessment, so that we can predict them and intervene them actually at the right time when you get the opportunity, by giving them anticipatory guidance and spot the risk factors, assess, refer, and manage the problems. So you can, when the parents come, you can help them in improving their parental skills and interpersonal skills, and of course life skills. So you can have activities in the school. You can talk them about the life skills, take them and involve the peer groups. And of course, definitely the religious involvement and maintaining the family events and rituals. This family connectedness will definitely make the adolescents avoid from taking any risk-taking behavior. So definitely focus on the health and safety while assisting with healthy lifestyle choices. Please go back to the previous slide, ma'am. So this adolescents, they must have an access to mental health, because this risk-taking behavior definitely has an underlying, this recurrent risk-taking behavior has got a underlying mental health issues like ADHD, impulsive control disorder, and oppositional defiant disorders. So definitely they must have unless you treat them, you will not able to avoid this recurrent risk-taking behavior. So the access to mental health should be there. And of course, there must be some this contraceptive services, and they must know how to use it, and they must be taught about abstinence. And of course, raising the driving age and strict tests to issue licenses have to be formulated by the governmental policies, limiting adolescent smoking, substance abuse, teenage pregnancy, and of course, automobile accidents have been rampant. These have to be taken care of by enforcing strict test for this issuing this licenses. Otherwise, it's going to be a problem. So vigilantly enforcing the laws and sale of alcohol, this has to be very, very kept in mind by the policymakers also for prevention, to get a good society with the lesser risk-taking behavior in adolescents, because their adolescent brain is not yet mature to handle these problems.
True. I know of a school where my son was studying, and the principal would be out during the early hours when the students were coming in, and he would insist on the helmet if they were on a scooty. And many a times he would go himself checking on the learner's license also. So there are some things which are negotiable and some things which are not negotiable. As Dr. Senthil was saying, safety issues, not negotiable. If they want to go and make a punk style hair, fine, it is negotiable. We can allow them. Tomorrow they'll lose the interest in that and they'll come back. If they want to eat something for a day or two, they will come back. But with such kind of things as substance abuse, as drunken driving, these are non-negotiable. So the parents also and the schools also must make them understand that there is going to be no negotiation in this. And they are now adolescents who are now responsible, and they should become good citizens and responsible citizens of India. So thank you, Senthil, for that brilliant presentation of the case that you gave us. So May is the month of mental health. So let us talk about some mental health. I will invite Dr. Manmeet now to talk on depression and adolescent suicide. So Manmeet, are you here?
Ma'am.
Okay.
Thank you so much.
So this is your case. Can you please detail the case as it came to you and how you went about this?
Yeah, it was very wonderful listening to both Dr. Sumita and Dr. Senthil. And as you already have told that this is the month for mental health. And I think the most vulnerable period for mental health comes across in the adolescent years. And this is one case of a class 11 student, Reena. She presented with disturbed sleep. She was not sleeping well for almost 1 year and not eating well as well, and was very irritable. The parents were saying that she has frequent anger outbursts and mood swings. For the last 3 unit tests that she appeared in her tuition classes, she were having poor grades, which were deteriorating by the day. And in the last maths test, she failed totally. Now she was refusing to attend the classes at school, and both at school and tuition, for the last 1 month. And whenever the mother used to ask, "What's wrong with you? What's happening?" she used to shout back at her that, "I don't want to study. I just feel like ending my life."
So this child that you are talking about, so how can you assess this kind of a patient? How do you go about this kind of a patient who says that I feel like ending my life?
So I think whenever this type of history comes around to a pediatrician or any healthcare professional, even if a teacher gets to hear this, I think it should set the alarms ringing, because this statement actually tells us that this person, this adolescent, is having a troubled mind and is thinking about ending the life, that is committing a suicide. So for this, obviously, we take help of the head's assessment, and in most cases, we have to find out what are the risk factors or the triggers, what made the adolescent say about this. Obviously, we have some office-friendly screening tools like the Ask for Suicide Risk Screening tool, but I would like to make an emphasis on finding out the risk factors first. So if we can have the next slide, which talks about the risk factors, one before this one, the risk factors. Our risk factors, if we see, so when we take the heads assessment for this adolescent, we may find a psychiatric disorder, or there could be a history by the adolescent herself that she tried to do something about ending her life. A very important history to take out from these adolescents is about any physical, sexual, or drug abuse by them, any sexuality issues, any stressors that they have around. This girl had not fared well in her 10th exam, and the parents were constantly telling her that this is the only year that you have to, build up your grades and everything, because the +2 is very difficult, and you have to, have something to show to us, good grades at the end of it. Important component is the family history, where we could have history of a psychiatric disorder or suicide in the family, any family discord or loss of a parent, or substance misuse in the parents as well. Another component of the history could include going through what is happening at the school level. What are her academic performances? Are they deteriorating? As we saw in this case, that she was not taking any interest in the studies. There were falling grades, and that was because of a stressor that parents want her to do better in the +2 exam. Then this is the only year left. So this is about negative school environment, any peer pressure, bullying by the peer group or the friends, lack of supportive friends, poor academic performance, as was seen in this case. Other than that, a very important risk factor is availability of legal means. Sometimes these adolescents can start storing things which they think can work up about ending their life. Important thing is about copycat suicide. Copycat suicide is like, we understand it very well about what they get from the media or other things. And then there are other trigger factors that may cause the adolescent to think about ending life. So what are those trigger factors? So during the heads assessment, we are able to assess, like in this case, it was the exam failure. She did not do well in the 10th standard exam, and all the pressure was building on her in the 11th grade. Other causes could be a relationship breakup. We all know that the adolescents at this stage venture into the opposite sex. They start having crush on the opposite sex, or there are sometimes serious involvements as far as they start looking forward to a long-term relationship, and sometimes that may not materialize. There could be emotional blackmailing, bullying, fear of complications of wrong deeds. There's another example that I would like to quote here, that one of our disciplinary committee member discussed with me that they caught one of the hostel student who was in the second phase of MBBS with hookah in his room. So once he was caught, that disciplinary crisis, that what will happen to me, what will happen when they will tell it to my parents, when everybody will know about this, that was such a bad emphasis on him that he started having negative thoughts. He thought that it's better to jump out of the hostel room rather than getting these things out in the open to my friends and family. So this can also be seen in cases of sexual assault. Sometimes these challenges take serious turn, and sometimes they get occupied with thoughts when they see on media that some celebrity has committed suicide. So that actually has a negative influence them. They think that it is something which is very glamorous. That person, she was in the TV serial and she suddenly committed suicide. To see certain young, TV and film actresses and actors committing suicide, and that actually burdens these youngsters' mind. and any event which leads to feeling of being trapped. Sometimes they buy something online, they spend a lot of money, which they must have even stolen from their parents, pocket, or somehow they've taken. And suddenly when those things don't turn up correctly, they feel that they are being trapped. And the only way out they feel is to end their life. So these all can be trigger factors for youngsters.
So, Manmeet, I remember there was a book called I Can Tell You Because You Are a Doctor. So, many a times they will confide in their doctor uncles and aunties. Can you detail a few warning signs in these children? So, if we can pick them up early.
See, while talking to such an adolescent who is mentioning about ending his life, so there will be subtle, mentions about acquiring certain means. Like I have read on the Google that this drug is used for suicide. Their searches can sometimes show that how to kill myself. So they can even have a history on Google showing how to commit suicide or how to end my life. This total feeling of hopelessness and unusual cheerfulness will be there in certain patients who don't want to show that inside what going inside them. They will start hating themselves, doing some final preparations, and then they will start doing some goodbyes. Like if they borrowed a book from somebody, now just go and say that now you keep this book, I don't need it anymore, I will not be there for long to read this book. So you just keep it. So just start giving back things. And sometimes even start giving back, giving things to other people which they love the most. So like any film or any film CD which they like too much, or a book, they will start giving it to someone because that's like a final goodbye. I'm giving away my things, I'm leaving this world. So there's a social withdrawal and there are high risk behaviors. So these are the warning signs that if the history or during the assessment, whenever you feel the patient or the mother or the father tells you about this, that is the warning sign for the suicide.
So, having said these warning signs are there, supposing we recognize them also. So, what do we do? Do we refer? Do we hospitalize? What do we do to these cases? Like the case that you quoted right now. She says a feeling of hopelessness. What will you do to this child?
Well, in this case that we were discussing, so we have to think about being a high risk case, especially if there is any previous attempt by the adolescent to think about committing suicide. So in the previous case that we talked about, Reena, her mother was telling me that she was terrified to see that her Google history has a search like how to end life. So that means she was already preparing or finding means to do it. So that is important point for referral. So we have to explain this need to the adolescent as well and the parents. The parents may become very anxious once you tell that your adolescent is prone to be committing a suicide. So they get very anxious. But we have to tell them that don't worry about anything. One has to refer them to a psychiatrist. And sometimes we need to hospitalize these adolescents when there are recurrent thoughts of suicide. So they're preoccupied by the thought. One thought comes, the other thought comes, but everything is about ending the life. There is high level of intent to die in the future. Even if say they that may not attempt right now, but they think there's a stage of agitation or panic. And there is existence of a clear plan to use some methods which may be even violent. So for that, we need to ensure that we have arranged everything at the other end with the psychiatrist, and then transfer the child or the adolescent with the family member's supervision totally during the transportation. The adolescent is not to be left alone or transported alone. So everything has to be arranged first, and then the adolescent needs to be transferred.
So the message goes loud and clear that any child who thinks has a suicidal tendency should definitely be referred to a psychiatrist. And another thing is that this child should not be left alone, because many a time, if you are there or if somebody is there with this child, the impulsive nature of the child, which makes him commit the suicide, will actually, that moment, once it passes off, maybe a little more stability, we get a little more time to save this child. So there are, of course, methods, means and ways to hold the child till somebody else can come and take over this child. So many a time they will attempt further suicidal attempts also. So it is a clear message to the pediatrician community: never keep such child with yourself. Refer them to a psychiatrist friend who will take due care of this child, and you may need to hospitalize also. So there's a mnemonic with suicide, Dr. Manmeet.
This is just to sum up how to approach the case in a, just mnemonic keeps us reminding what we need to do. First of all, we need to stay calm. It's not about like, तुम ये क्या करना चाह रहे हो, ऐसा नहीं है, because they have lost their logic to live. They're not finding any reason to live. They found so many reasons not to live. So if you tell them aisa nahi hai, waisa nahi hai, this is not going to work. You have to stay connected with the thought process of the adolescent, understand what is stressing him, and there are certain emotions that are actually locked up. You have to give a vent to their feelings. Let the adolescent come out with what does he want to change, what has been wrong with him, what he thinks is not working well. So you need to talk everything to him. And it is very important, like in a case of a hosteler or somebody who's living away from the parents, immediate information to the local guardian or the parent needs to be given. Contact helpline if there is no one available. Induce positive behavior, discussing all the options. We can tell them that, see, you think of only ending the life, but this options we can discuss about. And definitely you can also find those options. Just calm down, just think about it. You will have so many options. Ending your life is not the only option. As ma'am already told, we need not give him that aisa nahi hona chahiye, waisa nahi hona chahiye. What can be done, that has to be told him. If you start preaching, then he will think that he is just like others who have created so much of negative environment for me, my problems. We can sometimes use drugs for the mental health disorders which are underlying cause for the suicide, and if there is any drug abuse, that needs to be managed accordingly, and eliminate all means for the attempt. So don't leave the adolescent alone, because definitely he has had a plan in his mind and we need not let him be alone to do that. So be with the adolescent all the time. This is just a small moment to remember what we can do.
So Manmeet, you reminded me of a very famous song which we used to sing in our teenage days, ये जीवन मिटाना है दीवानापन, ये जीवन तुम्हारा तुम्हारा नहीं, सारे जहां की अमानत है ये जीवन तुम्हारा तुम्हारा नहीं. So they should be reminded that they have family, they have friends who are looking forward to seeing them again. So the suicide is not the way out actually. So positivity can be induced. They should learn how to face their failures and then go ahead with a positive mind. Now, this is a case, Manmeet, 17-year-old Manhar, he lives with his parents, he's in class 12. For the past 6 months, he doesn't sleep well, gets up often. He stopped meeting his friends and avoids going out to family, these things, social occasions, irritable, shouts back at the parents, and has stopped going to even his favorite chess classes. So tell me now, what do you think? Is this child in depression?
Yeah, as is very clear that we see from symptoms, he's in a very low mood, has no energy to do good things, and it's been there for more than 2 weeks. So that is how under the DSM-5 we see that if the symptoms are for at least 2 weeks present, and these are the core symptoms of depression: low mood, not being present, the loss of feeling pleasure, low on energy, all were there in this adolescent who was in the class 12 and around 17 years old, Manhar. Naam was Manhar, but at that moment he was not having any Manhar thoughts, any good thoughts about himself. And along with that, he was thinking about all things bad, that things will never be good for me. I will just be bad. Everything is going down. Everything around me is bad. He could not sleep well and was not even eating well. So these are all symptoms that we identify, and these are symptoms that qualify the patient as to be having depression. So other
So
could
the
be even
management
thought of
part,
creating
let us come to that. What would you like to
again, we do a complete heads assessment, and most of the time we can use the PHQ-2 for screening, and even the Beck's depression inventory that can help us to monitor what is the severity. But I would only emphasize on the point that the pediatrician needs to estimate or understand that these features are just not any symptoms. Sometimes we tend to ignore, अच्छा नहीं खा रहा है, नहीं सो रहा है, हो जाएगा ठीक, कोई बात होगी. There is important point in that. We need to read in between the lines. It will take some time for the adolescent to confide in you and come out with the problem. But if you see these core symptoms, please do not ignore. Not just think, koi baat nahi, aise there's seasonal change, he's feeling low on energy, he'll feel good one day. So that days of delaying the thing will be lost. So try to assess and take a detailed history. Sit with the adolescent. Definitely, you will find a cause or the reason for the depressive behavior. So we can use these questionnaires, and then if required, if there has been a long history of poor school performance, then psychoeducational assessment could also be done in such adolescents.
What about medication, Manmeet?
Medications, pharmacotherapy we can use, but I think we need a complete heads assessment to rule out underlying psychiatric illnesses. The commonest drugs that we can use are the SSRIs, and fluoxetine is one of them. We can start at 10 milligram OD, and slowly we can increase to a dose of 20 to 40, but continue the treatment over a period of around 9 to 12 months. Keep in mind the side effects, and the adolescent can be told that these are the common side effects, because weight gain can be seen in young adolescent girls, and sometimes they become preoccupied with the thought that why we are gaining weight, and that can actually be a conflicting thing as far the coming up of the treatment is come. And sometimes it may precipitate manic episode if the adolescent is taking any other drugs. There could be inhibition of the 450 enzyme leading to some drug interactions that can be kept in mind. But the mainstay of treatment is still the psychosocial assessment and psychosocial management that needs to be emphasized in the case of depression. We have to tell the adolescent to have stress management techniques. This patient of depression was feeling very low. So you need to build up self-esteem. You have to put in a lot of positivity that you are worth a lot of many things. Sometimes start devaluing themselves. They think they're worth nothing. So you have to tell them that you have a value, you have a connection with the world, with your family. You have to feel loved. You have to tell them that there are people around you who want you to be there. Then problem solving techniques, and they can maintain a mood diary. It helps them, like what brings them down, what keeps them up. So there are so many other activities that they can indulge in. Like some of the adolescents would have a very pleasurable feeling while they read a good book, listen to a good music, their favorite music. So we can tell them that you maintain a mood diary and try to solve your own problems with it. And basically, it is a life skill education for them. So we need to tell them to take care of their educational problems. If there is anything that is hindering their good school performance, that needs to be taken care of. And the teachers have to be brought in to rebuild the connection with the school. It is seen that most of the adolescents who are in depression also have poor school performance. So which could be a vicious circle, one thing leading to the other, that needs to be taken care of. Family comes very important when dealing with depression of adolescent. So parenting programs and family therapy also has to be taken. And some of the peer group a dear friend, a close friend, a confidant. He has to be taken in while you're discussing the psychosocial management, because he can be the game changer, because he can be there 24/7 for him when everyone is not around. So we need to create opportunities to mix with more peers. And if there is a person who can take up the, the management part with you, especially from the friend circle, that helps a lot.
So correct. When we say that connectedness, we talk about a little bit of connectedness with the family, with the parents, with their brothers and sisters and other siblings, and of course, connectedness with their peers. And one more connectedness is with God up there. So spirituality always helps children who are a little stressed. And for sure, stress management techniques should be taught to them. For us pediatricians, it is essential that we learn some counseling, a little bit of it. So the basic counseling, as Dr. Senthil was saying, the prerequisites are privacy, confidentiality, with an assent from the adolescent. He cannot give consent. Remember, he's not yet 18, and a consent from the parents. We have to be respectful. You cannot tell them, "Arey bacha hai, chup ja." So they respect us, and it is with us that we should return that respect and be empathetic with open-ended questions. And we must remember that it is the non-verbal communication skill which is more important. A little touch or a pat on the shoulder, a little moving forward, giving him your time and your concentration. These are important things which the child will understand, and he will come back to you. And as all the three participants have stressed, heads is the psychosocial interviewing part that really, really helps in basic counseling. Remember, I said confidentiality, but there are caveats to confidentiality. If there is a sexual abuse, if there is a suicidal behavior, if there is a crime committed, or if it is a medical legal case, or the case requires hospitalization, there can be breach of confidentiality. But it would be good to tell the adolescent, see, it is going to cause you harm or the society harm at large. So we will maintain a little bit of confidentiality. Keep the principle as KISS principle, keep it short and sweet, use I language, use apt words and open-ended questionnaires. So these are a few helplines which I have given over here. Child helpline, I call, and there are many others such in Bombay, in Calcutta, in Assam, where you will find these helplines very, very helpful. So if the pediatrician, if a child knows that anybody is going to commit suicide, please hold hands and please be there till somebody else takes over. Thank you, Manmeet. So now I will call my last participant, but not the least, Dr. Navendu. Dr. Navendu is our EB member of the Central IIP. And thank you, Navendu, for being with us. We will be talking on the screen time guidelines. So what are the common questions that the parents come to you with?
Good evening, ma'am. Thank you, Dr. Piali ma'am, Dr. Kripa Sindhu, Dr. Sukanta Chatterjee, and West Bengal Academy for giving an opportunity on this stage. I'm thankful. So as we all know that the screen time has definitely increased in post-COVID era. It started in COVID, and just before COVID, we had the advent of 4G services by almost most of the telecom operators, and now it's going to be 5G. So it was the 4G which had the fast data, easy availability of data, and so subsequently we had increased screen time. Not only the adolescents and children, but adults also had increased screen time. As we all can see during the metro, in the bus, or whether in the car, wherever we see the adults are also stuck up to their phones watching something. So the parents also have that concern that the children are having screen time, and mostly the parents ask what the effect the screen time is having on their children, and for how they are also concerned that for how long the children should use the screen, and how much the screen time should be limited to, and
Correct.
what is the effect of prolonged screen time on their child, and whether the how much duration for the children should be allowed on the social media, and at what age they should be exposed to the social media, and how can I make children follow good online manners, as this social media, Facebook, Twitter, YouTube, and all these are now social media, they are easily accessible, and we also see that many school going children, even in their fourth, fifth, or sixth standards, they are on the social media, they are on the Facebook, they are on LinkedIn, they are on your YouTube, and they are children are also having their channels also, and some parents allow that. So actually, what the screen time is the total time spent per day in viewing screens, all kinds of screens, whether it is a mobile, it is a TV, or it is computer, or it's tablet, or any handheld visual device. And if any of the ancestral activities such as sleep, physical activity, study, or their family meal, hobby times, or their timeouts, they are affected, then that is definitely increased screen time or excessive screen time, and it should be avoided for a healthy state of mind of the child and the healthy state of mind of the family members as well.
So is it
And it's
always
all,
harmful, Dr. Novindu?
it's not always harmful, provided that if it is used for educational purposes and some recreational purposes. As in the COVID also, I can give the example of my daughter. We say that less than 2 years, there should be no screen time. In 2 to 5 years, there should not be more than 1 hour school time. But she was in a UKG, and all the classes were on mobile. So when you are having classes on the mobile, you cannot dictate your child to not to watch a cartoon on the mobile, not to watch a video game on the mobile. They just question you that if you are making me study on the mobile, why you're not allowing me to get entertainment on the mobile.
So many
So that,
children must have landed into mobile addictions as well.
yes, ma'am, it was just the COVID era, which and even when we can see that the governments provided the mobiles and tablets free of cost for education to the children in many government schools, and the private school also recommended that you buy a tablet or mobile so that we can have online classes and online teaching. That online teaching ultimately then that increased the screen time, and the screen time other than educational activities was justified by the children, that if you can justify the education on the mobile, then why not to justify the other activities on the mobile. So that is it's currently going on like this only.
So
It's
one
very difficult.
offshoot that we have is fake autism cases that we've been getting because of
Yeah.
excessive use of these mobiles and loneliness in the child during the COVID times. So when you say that, what is the unhealthy will the screen time will affect the child's psychiatry. But what about his day-to-day life? Is it affected by this thing?
Actually, the unhealthy media usage, it always affects his physical and psychological and social and mental well-being, and most importantly, the academic well-being. If it's not used for the academic purposes, and however, to avoid that and to save the children from that, we can implement some digital rules and some digital hygiene, that which thing needs to be viewed and which thing doesn't needs to be viewed, and most importantly, that we also need to inculcate online and digital discipline in ourselves also. The children do what the parents and family
Parents do.
members.
Mm. So all the mothers
So,
and
and we
fathers
should
are
act
on
as
the
a role
mobile. So
model.
how can you say no? Mm.
Yeah, and we all are facing this problem in our households, and we are not
Correct.
leaving the phones, and we are preaching the children to leave the mobile phones.
True. True. So what are the guidelines? Has IAP some guidelines, or are we following the AAP guidelines? Have we come out with something?
Yeah,
IAP?
IAP has some screen time recommendations, and which says that and which is derived from various other institutions. And so the children below the 2 years of age should not be exposed to any of the screens. Family
No nursery
member,
rhymes on television? No
no,
rhymes on television?
no rhymes on television, I think. because if the rhymes on television, if the things on the mobile, then there we can face the isolated language delay also. There
True.
won't be that much stimulation, and we face such cases off and on, because at 3 years of age we all on an average we always have 3 to 5 kids like that in our OPD. They are 3.5 years old, 3 years old, and the parents are complaining that they are not vocalizing. And on history, always that he sees the mobile. So when the input is there and the output is not there,
Yes.
so they have all the visual input and auditory input, but since they cannot talk to a mobile, so why should they talk to us? Why should they talk to others? So that's the problem. So I think the interactive play, the interaction between the children, between among themselves and the family members, that will have neurostimulation, and they will have a better IQ. And so that's why the role of Anganwadi comes in. I think the Anganwadi is the best thing for a toddler to spend that early time for good stimulation. And the screen time for the children between 2 to 5 years age should not exceed 1 hour. But however, I think even my daughter also, off and on, off the record, on the record, she may be having more than 1 hour screen time. So that's a difficult thing more for me to also control. And for older children and adolescents, it's important for to balance screen time with other activities, which doesn't affect their physical well-being and their mental well-being, and doesn't affect their academics as well. So these activities, it includes an hour of physical activity, playtime, adequate duration of sleep. 8 to 9 hours of uninterrupted sleep is required. That is possible only when if you have less and less of screen time. And if any of these activities is displaced due to screen use, the routine activities which keeps them healthy, then that is definitely an excessive screen time.
So this is how we go about it. So during the first few years of the baby's development, it is more of a social bonding. We look for a social smile, we look for a social interaction, and it is crucial for them to understand that the world around them, how it is for the cognitive development of the child. So the recommendations which come, Dr. Navendu, is fine-tune skills, isn't it?
Yeah, it fine tunes the skills, and it one should engage the children in activities that develop their motor skills and that stimulates their senses. And just for example, some building blocks, colorful toys, or something like that can be given. And
Correct. And
playtime,
story time, which we used to have, our parents and our grandparents used
grandmothers,
to tell us
grandparents.
all those stories from Jataka tales, Panchatantra, and put us to sleep at night with those stories buzzing in our mind. So story time is, of course, very, very good. What about the little older child, 3 to 5 years?
So in 3 to 5 years old, not more than 1 hour of screen time per day should be allowed. And as the child grows and they have some feeling of independence, they have some feeling of they want to have some liberties. So these can be done though, so they can be regulated by the tech free zones. For example, if they are on the dining table, no device to be allowed. If they are in the bedroom, they are about to sleep, no device should be allowed. And moreover, before sleep, at least 1 hour prior, no device should be allowed, because it's a stimulator and disturbs the sleep as well. So for that, we need to set an example. We should not have phone on the dining table. We should not have phone in the when we are about to go to bed. So and the many things like that. Even nowadays, the children do not eat breakfast even without mobile. So that's what we are seeing. And even
It comes from day zero, the whole thing, the control or developing the mobile free habits. They come from day zero, and we as role models should be promoting them to healthy mobile use rather than anything else. So when they are a little older, maybe if Navendu, you and your wife can have those mobile free areas or tech free zones, maybe your daughter will learn when to discard it and come and sit at the dining table and tell her about her whole day. tell you that, Baba, this is what I have done the whole day, talk to you, and how was your day, and things of that kind. Otherwise, the conversation will not flow, and you will not be able to understand the child's daily routine or her troubles and her fears. Those things must be understood by the way of communication or socialization. And of course, we cannot impose on them and say that don't do this or don't do. If you remember, the whole day we keep saying no. No, don't sit there. No, don't move like that. No, don't take that. So instead of that, we should have alternatives. Giving them fun alternatives will help. Let's play this. Let's look at this. Let's read a story together. I think fun alternatives will always help in the older children, because they do want to know how you are doing. Like my sons used to ask me, how was your childhood? What did you do in your childhood? Where are your mark sheets? We'd also like to know how much marks you used to get. So things of that kind, maybe you take them out for a stroll outside, and then you tell them a story while you are walking down the road. So these things always help. So being a role model. But as they grow, they enter their puberty, they become adolescents, they become 13 plus. So what are the recommendations then?
So when they are 13 plus, then we should have discipline, and they have screen time as much we allow them, because that in the adolescent age they can have access to any kind of activity on the phone, maybe some adult content and some societal content. They know what to search, they know how to search, and they are inspired by the, which we discussed earlier, that some celebrity commits suicide and some celebrity did such a thing, and they learn how to search, and then they find out the ways how to take out their anger, how to take out their frustration, and the mobile cannot tell a good thing, and they
So
start searching
pornography
good
is
things.
another issue. You need to find out whether the child is watching pornography also. Of course, there are some child locks, but they are more intelligent than us. They will break those child locks and codes, and they will enter into forbidden territory also. So many
And
a time
sometimes,
we need to look into the computer, laptop, mobile to see what they are watching.
and most of the times parents complain that he used to study for whole night, and ultimately in the end result he passed barely. And on history taking, when it is found that either they are playing some game, they are PUBG, they are ducking inside the blanket, they're ducking inside the quilt, and watching all sorts of stuff. And parents think that they are studying and studying and studying, and the light is on.
They're
So
fooling their parents also.
they are fooling their parents, and that's a very common problem.
So you talked about the Facebook, Twitter, and all those things. So can we have the minimum permissible age for that?
Yeah, minimum recommended permissible age for the social media platforms, that is Facebook, Twitter, and basically group social media platforms. It is 13 years,
13
and
plus.
for 13 plus, and
So
for
many of these
exposure,
children also make fake accounts.
they make fake accounts, and after say, when we were previously saying that at the 6 years of age children, they know all about the mobile, but I think now 3 to 4 year old children, they know everything about the mobile.
They are
What
sharper
to
than
get,
us.
what to get, and how to lock, how to unlock, and everything they can. Even they can go into settings, and they can have settings for the grandparents also. What do you want? So
Correct,
for
correct.
WhatsApp, minimum permissible age is 16 years. For YouTube, it is 18 years, and 13 to 18 years is recommended only by the permission of the
Parental.
parents. What content they want to see, and what content they should be allowed into.
Correct.
And although PUBG, I don't like this game actually, but the recommended age is for 18 years, and for 13 to 18 years, it is the some we should have
Restricted.
restricted play time.
So
And
my
Clash of
PUBG
Clans,
experience was very nice. One day at midnight, I was thirsty and I wanted to have some water. So I came out of my bedroom and from the side room, from my son's room, somebody was screaming, "Are chhod de, chhod de, chhod de! Are maar de, maar de, maar de!" And I was so sort of this thinking, what is happening in my son's room? So I quickly walked into his room. He was playing PUBG and he was asking his friends to do things. So sometimes, it is so addictive for them. For the days on end, they will play PUBG. And I know one child who was taken to the shut clinic at Nimhans, who would pass urine, stool, everything in bed for days together playing PUBG, and he wouldn't go. So ultimately, he had to be admitted in Nimhans.
Yes, we have many stories like that.
So what about the 20 into 20 into 20 rule?
So 20-20 rule is that when we are having a screen time, as we say that 1 hour of screen time is allowed. And so every 20 minutes, we should take a break of 20 seconds and we should look at the object 20 feet away to maintain our visual acuity and de-stress our eyes.
So in addition to the mental health problems, we also have a lot of physical health problems, including eye watering, eye strain, neck problems, the wrist problems, a lot of them. So the effects on physical and mental health are there. Can you detail just a few of them?
So as we all know that prolonged screen times means prolonged sitting. So the obesity, sedentary lifestyle, overeating, disturbed sleep, headache, eye strain, neck, back, and wrist pains by holding mobiles. That all can happen. And in mental health issues, we can have hyperactivity, depression. We already talked about, and delayed speech, and a fear of missing out, a fear of being left out. And sometimes the children can get caught into some online frauds or online something cyberbullying or and distorted they can have distorted perception of the sex by exposure to the pornography. And even drug use they can get into drug abuse, self harm. They can do self harm. They can learn some self harming things and some bad drugs about, and smoking. Though actually the content on this internet is not censored one, so that is not censored, so they can have access to the uncensored content, which have a negative impact on their mental health.
One of
And,
my children came crying to me saying that she is very depressed because she did not get 100 likes on Facebook. So even that is there, they go into depression because their likes are not enough.
Likes are not enough.
Yeah.
And once they are stuck up to the screen, they have reduced socialization. And reduced socialization, then they do not have that much friends. And mostly the online friends are there. No physical friends are lost somewhere. They have online friends. We whom they have never met, never talked to, but they are online friends now.
So how can parents help these children?
So as we already said that we can help the children only by we should be role models for them. So that is the best help we will be doing. And we should encourage the use of media for educational purposes and promote the physical activity, help them to make a balance between screen time and physical activity. And offline creative games should be encouraged, the cricket, football, or they should be given some time in the evening to go outside and play, just like our older times. Previously, when in our younger times, we used to go during our school, we used to go daily for 1 hour with our group of friends to play in the playground. Now that thing is lost, and especially after the COVID, that thing is almost missing. And we should have digital free zones, such as no phone, no digital, no media in bedroom, dining table, kitchen, bathroom, or in the vehicles. And though we should have a discipline that no family member uses a gadget in these areas. They are to be marked as digital free zones. And one can have a digital fasting also. At that time, no family member uses a device. We can have self discipline for that, and that time can be utilized for increasing the family bonding, increasing the interaction, and discussing your problems with each other. That can be de-stressing.
So can you summarize what are the key points?
So screen time is the total time spent per day in viewing all types of screens like mobile, TV, computer, tablet, or any handheld visual device. And if any of the essential activities such as sleep, your physical activity, study, family, meal, or free times or hobby times are displaced due to your excessive use of the screen, then it is called excessive screen time and it should be reduced. And we should avoid the use of digital devices in the children less than 2 years, and in 2 to 5 years not more than 1 hour of screen time is used. And healthy media usage, it promotes learning, creativity, and social interaction. Not all things are hazardous in the digital media, but some things are helpful too, to gain some knowledge also. And unhealthy media usage, it affects physical, psychological, social, and academic well-being. And we should implement digital rules, digital hygiene, and nurture responsible digital citizenship among the children. And we should be the role models for that. And if there are some signs of media addiction, then we must consult a mental health professional, and so it needs to be held upon. And we should act as a role model for healthy media use.
Thank you so much, Navindu. That was brilliant. And thank you, all the panelists. So, Shukantada, do you think we should talk about junks a little, or should we stop over here?
Well, it is already been
Quite late.
Yeah, we can have a
yes,
junk
more
in
than
another day.
10:30.
Yeah, we can
Yes,
have a junks in another
I
day.
think yes. So I, on behalf of everyone, we must thank. I am remembering my adolescent days that regarding the body image issues Sumita was talking. That I used to have rest my ears always, and that was an issue. Maybe I was having some body image issue at that time. I don't know. I didn't know at that time. Subsequently, I came to know it. So similarly, at Navindu was telling the screen time, this is the new issue. Maybe some DSM scale and classifications will come in future days. Let's wait for that. So I must thank the WBAP, and I request Kalpana Datta to ultimately give the concluding remarks, summarize.
I think if there is any note from the chairpersons, anyone, anything to say from chairpersons?
An excellent discussion, and as we all know, Piyalidi was so enthusiastic. She took up a lot of cases and a lot of case scenarios. So the time was something which is a scarce commodity when Piyali ma'am is at the helm of affairs. So that's why we had to drop the junks. But anyhow, the discussions were very important, and all the topics has been thoroughly covered. The common thing about adolescent, that parenting, for the parenting of the teens, that is you have to build the self-esteem. You have to keep the connect with the child, so that the child, whenever at any issues, the child is free to communicate with you, as well as the child should have realistic expectations from himself or herself. So these three things are very important in all aspects,
Hello.
whether it's the body image or it's with suicide or depression activities. And regarding the screen time, now this is a big challenge for all of us to be good role models. And I believe we must do our bit to be good role models. Thank you.
Thank you all. And especially I must thank the Piyali ma'am to
Is Amit Kumar there? Is Amit Kumar there?
Yes, Amit is there. Dr. Amit,
Yes,
you want to say
yes,
something?
yes. Yes, no, I don't have to add anything. It was excellent. And I think Piali ma'am and others have planned it so well that it covers all the important topics. And I have come out very wise after attending this webinar. Thank you very much, Piali ma'am. As expected, you were excellent.
So I have to thank all my 4 panelists. I wish Dr. Hemant Jain had been over here also, but he had to go away for a visa appointment, so he couldn't come. So I'm very thankful to you, Sumita, Manmeet, Dr. Navendu. All of you did such a brilliant job. Senthil to unparalleled, all of you. So you made my job so much easier quoting the cases, and it was a brilliant discussion. Thank you, my panelists.
Thank you.
But before you go away, Piyali ma'am, the song you told, I thought I have never heard, but then I realized it was of your childhood, not of our childhood.
No, you must have heard of it. You must have heard of it. It's a very famous song.
Yes, ma'am.
I think Dr. Adarsh is also there. Adarsh, are you there? Dr. Adarsh?
मैम एक गीत और था ना, जीवन चलने का नाम.
Yes, that's also there.
These were motivational songs in those times.
Lovely songs,
And
you know.
they
ये
used to set
जीवन
the,
तुम्हारा तुम्हारा नहीं, जीवन मिटाना है दीवानापन, कोई प्यार जीवन से प्यारा नहीं. It was a beautiful song.
wonderful.
Wow,
Beautiful, ma'am.
excellent.
Beautifully sung
It's
as
being
well.
recorded, really, it's being recorded.
There has been some requests,
Now there
there
is
has been some request of the recording. It will be there in the YouTube. I will put the YouTube channel,
Open, yeah.
just contact any of the panelists. So they will provide you the YouTube channel. And in between, Dr. Geeta Patil and Dr. Adarsh had also joined. But
So ask if they want to have some comments.
Um,
Dr. Geeta Patil and Dr.
Geeta ma'am, are you there?
Yes, I'm there. I think.
Ma'am, please
I-
put on
I-
your video and just say two
Problem.
words.
Yes, Dr.
Sir-
Geeta Patil, madam, please, your comments.
Dr. Navendu has answered so well. Only thing I just want to add about media diet. I think Piyali madam knows. Talk about media diet. We talk about the diet should be wholesome. So same way media diet should be correct balance of everything. And then every family has got a different requirement of the screen time. So family media plan is also very important. And Navendu was telling that should we show nursery rhymes in the cartoon form? See, the people who have attended ECD, in that it is told, cartoon nursery rhymes, don't do it. But if you do, actually the children dancing, means that is okay, but not a cartoons singing some songs and dancing. So that is the screen time thing. And it was excellent presentation. And screen time is screen has become so pervasive that all the age groups, including us, we are glued to the screen in all the formats. And I could not attend the previous one. I just was joined at the end when Manmeet madam was presenting. But I think the way it was coordinated by Dr. Piyali, as usual, it was excellent and very informative. Thank you for giving me opportunity.
Thank you, Dr. Geeta
Thank you,
Patil, madam.
Geeta.
Dr. Adarsh, are you there? I think yes.
I think he's on the other panel. Okay.
Oh, okay, okay.
Arup Rai has joined.
Dr. Arup Rai, sir, if you want to say something.
No, lovely. I have given comment, but only I want to ask from Dr. Navendu, what about the IPL play is going on Dream 11? What that should be? I think this is not fair. It should be stop. Our big cricketers are giving this type of ad. Why for they are giving this type of ad for money?
Recently I had a news item that the government is planning to ban these IPL 11, Dream 11 sort of things, because they are just like your digital, what I mean to say,
Digital betting.
Digital pollution,
and this is the great addiction. And it should be dropped.
This is great addiction, and actually how they are doing it, because on the Facebook they are having a page. It just looks like a normal page, and that they'll share it like a news item that Dr. Arup sir was playing Dream 11, and after 6 balls and spending 10 rupees, he earned 1.5 crore rupees. So, and that's how the people like us will be attracted, that Dr. Arup Roy won 1.5 crores. I must also get into the queue to win 1.5 crore rupees, and that's how we get addicted. And many people are getting into that.
Thanks,
That
Dr.
increases
Piyali.
screen time as well,
Lovely, great session. And all our
and that
panelists.
drains your wallets also.
Or Uday has earned 5 crore, not 1.5, 5 crore.
So I think special thanks to AHA and the different district branches which are coming up and doing a splendid work. But I'm sorry, Dr. Senthil and myself tried most in the SGM, but we could not stop the resolution. But I think the seniors should take it up again and try to modify so that we can have constructive work which is being done by all the AHA branches everywhere.
Yes, sir.
We'll continue to work. Don't worry. We'll continue to work within the limitations of IP rules regulations because we are all IP members.
But there are some preconceived notions, sir.
Oh yes, but we are sorry for that. We couldn't succeed in our own ideas and what we wanted. But it's not that every time a person's wish gets fulfilled, but that doesn't lead to depression and its consequences.
Long live AHA, sir. The more we increase in strength, the more people feel threatened. That is it.
Is it?
Well said, PLE
And
ma'am.
those who want to have a physical program, so Durgapur AHA, as Asansol Durgapur AHA will be organizing the national midterm at Durgapur. I think Shukandoda will declare the dates and send it to everyone.
Date is already fixed. Durgapur branch activity, but Ashim, you are here. You can declare it.
And they make a flyer and send it to everyone.
Absolutely. It's going to be the midterm national CME on 8th and 9th of July. It's a Saturday and a Sunday. And we from Asansol and Durgapur are inviting each and every one of you. We will be delighted to host you on the 8th and 9th of July at Durgapur. Please do come.
Asimda, we will be joining you.
Absolutely.
you.
It will be a delight. Delight, Chandra.
So thank you all. And we had a wonderful evening, a very learning sessions, are very much empowered. I think now we are more empowered to tackle the adolescents. And though it's a very little, we have to learn many more things. And someday we might have the different parenting styles or the junk foods and food nutrition and all those things. Different topics might be discussed later on. And I think this is today. Dr. Atanu, want to say something?
Thank you.
Otherwise, we can
Thank
close
you to
over
all
here.
the panelists and everyone.
Thank
Yeah,
you.
Thank you. Thank you all the
Thank you.
panelists.
Good night.
Everyone.
Good night.
Thank you.
And
Thank
faculty.
you.